Okay, so I want to talk about my paper for Donhauser's data ethics. And the paper topic I am doing is the use of racially linked medical data and microaggressions. So the first question you might kind of have with thinking about this is race even a concept scientifically? Essentially, the answer is no. However, genes for specific diseases may be uniquely associated with specific ancestries or geographic populations, which, as we'll see in a second, those usually tend to overlap quite a bit. So from here on out, when I say race, I'm really talking about ancestry because that's what's biologically relevant for the transmission of specific disease states. But race can be a stand-in for the more biologically relevant ancestry. So why even use racially linked or ancestrally linked medical data at all? So as a rough and fast rule, thinking about ancestry can lead some quite important data sets. It's mostly self-reported, but it can usually provide two really relevant pieces of information, even when self-reported. So the first is that they correlate with ancestrally linked diseases. So people who self-identify as specific races usually have diseases from that related ancestry. The second is that environmentally linked data points are also relevant for self-reported use of race. So people reporting as specific races usually have certain kinds of environmental factors that are relevant for clinicians, namely environmental exposure of pollution or other things. So it's medically useful. So we might wonder whether or not using it could constitute a microaggression. And I think the worry is valid. But for now, let's kind of just discuss genome-wide association studies, or GWAS, to kind of understand the data that I'm talking about that might be constitutive of a microaggression in the clinical setting. So GWAS are not really anything new. They've been around for quite some time. They can look at whole genomes, and they can see, they dissect it by, this is called a Manhattan plot. So when you get, say, 1 million participants, this is kind of what it looks like, where you have a breakdown by chromosome. The y-axis is the correlation of the gene with the trait. So each plot here is actually a specific gene. So the higher up it goes, the more linked it is to a specific kind of disease or trait, whatever you're looking at. So with this, we can kind of start to see consensus among self-reported race, self-reported forms of ancestry, and specific genes. So that's kind of how we can kind of start to find that these genes come from specific kinds of ancestries, and ultimately make that determination. So to get the other piece on the table, microaggressions. So the kind of microaggression we're going to be talking about is, it's going to be a counterfactual in the form of, but for this ancestry, it would not have the disease. So I think, following Thompson here, I think this would constitute a microaggression if incorrect, I suppose, and we'll get to those objections later. But verbal, environmental, non-automatic, communications and actions are not necessarily intentional. Microaggressions are considered to be verbal and non-verbal slights and or environments that communicate offensive content, including hostile, derogatory, and exoticizing messages to individuals from marginalized groups. So specifically, I think it could be seen as a derogatory or exoticizing kind of message to pose this kind of counterfactual in that form. So for instance, it might be posed in such a way that situates the person being diagnosed as unique or exotic, and that their genes are somehow to blame, and therefore their ancestry is to blame, which would be, I suppose, derogatory. So with that on the table, let's look at family data, which we don't think is particularly normatively problematic, and compare it to the use of broader genetic studies such as GWAS that do seem to inculcate ancestry in a really perhaps problematic way. So on the left side here, we have family, and over here we have the data that you could get over a number of generations with GWAS data. So pardon my inaccurate genealogy here, but so this is going to be the disease gene here and here. So in cases where we're diagnosing within the family, we could see either phenotypically or genotypically that a parent has a diseased gene or phenotype, and then do some genetic tests or look for that phenotype in you. And on the genealogical side, we could notice that you are from a particular kind of specific ancestry and know that that ancestry has a history of containing that disease gene. And then we could genotype you or run your genome in a kind of GWAS study, or look for the kinds of genes that are identified as disease genes in GWAS in you. So is there any significant normative GWAS here that is different on the family side from the GWAS side? I think there's two problems that are going to have us say no. The first one is that family data inculcates ancestry in cases of clear ancestry-linked diseases. So for instance, if we know that a specific kind of disease is genetically mediated and that it occurs unilaterally in one kind of ancestry, there's not a lot of these diseases, but there are some. When we're doing inside the family diagnosis setting, we're going to know, even if we use a narrow genetic test that's just saying yes or no, do you have this gene? That is going to that should, or at least it could, inculcate a explanation of the counterfactual we cited earlier, which is, but for your ancestry, you wouldn't have this disease. So that's not really going to get us out of the problem, right? Because if your parents have an ancestry linked disease and you have an ancestrally linked disease of the same kind, it's going to be clear that the explanation invoked is could be of the counterfactual you just mentioned. So the second one, which actually might just put the first one a bit more pointedly, so one's family is in the set of people that can help diagnose genetic diseases. So how can it be morally correct to diagnose someone based upon someone that, in this instance, let's just stipulate this family's from a similar ancestry as each other? So how can we say that doing this diagnosis of parents is going to be morally okay? But if we go over here and just pick someone out from, it's not as closely related, but more distantly related, that also has the disease, how is that any different, normally speaking? Well, I think one point could be that families share environments more than distantly related people, which could be relevant for disease states. But I don't think that's actually going to be ultimately problematic for us, especially when we get into kind of the solution for how we avoid microaggressions in these cases. So let's keep that in mind and move along. So conceptual reengineering has been an emerging kind of philosophical area. And so specifically, I want to talk about in terms of causal structures. And a good place to start is to ask, does the counterfactual, but for your ancestry, you would not have this disease, does that fully capture the causal structure of what's happening? And I'm going to say it doesn't. So like I said earlier, some diseases do seem to be genetically mediated in a way that doesn't super depend on the environment. But some, like schizophrenia, even though there's a very finite number of genes that are associated with it, does have environmental constraints that work to instantiate the phenotype. So this is the kind of conceptual reengineering I have in mind for disease states that are mediated both by genes and the environment. So if this is the full, of course, it's not the full causal structure, but so somebody in the past had a disease gene and they passed on to you. And it also depends on some kind of environmental factor. So this disease gene is mediated by this environmental factor. So we could ask the question, would saying that but for your ancestry, you would have this disease, does that capture the full story? And it doesn't seem to, right? So there's another element that is actually mediating this disease. And it's relevant, right? So just saying that would situate one's ancestry as uniquely problematic when it's not actually the case, because if we knock off this link, link to environment, we wouldn't have the disease. So I want to say that reengineering this concept, this causal concept, is going to prevent microaggressions for a number of reasons. But let's get into the objections to see kind of how this works out. So we might think that, well, counterfactuals are infinite. So if you're just proposing adding a counterfactual to kind of help address this microaggression problem, aren't there an infinite number of counterfactuals that you could raise that would problematize this? So how do we figure out which ones are relevant? So for example, but for a solar array causing a point mutation on this gene, you would not have this disease. So these are infinite in number. So how do we separate out the relevant ones from the irrelevant ones? And this needs more work, I have to admit, but I do want to say that I think clinicians have a relevant definition in mind. They think of relevant medical information. And these counterfactuals are just nothing but relevant medical information. So I want to kind of lean on them and maybe, flesh this out in the future to understand how clinicians understand relevant medical information. So this is intimately related to the first objection. So the causal model with environmental explanation still implicates ancestry as problematic. So we might think that if ancestrally linked counterfactuals are problematic, how are they less problematic when couched in a fuller causal explanation? So good. So first, it's just a correct scientific explanation. So not all clinically relevant explanations need to be, fully correct scientific explanations, but I think in this case it does because it's relevant for reasons of beneficence. So omitting such explanations which are relevant, which we talked about in the first objection, can't be construed as beneficent. So if I was planning a family, I would want a clinician to explain to me, perhaps not exactly in the counterfactual manner, but in some way, that I have a high risk for my kids having a disease, depending on what ancestry my partner's from. If they're from the same ancestry, we have a high risk of producing a disease state in our kid. And if they're not, then there might not be any risk. So we might ask, why can't we just recommend people get genetic tests when we know that they're at risk for genetic diseases that are ancestrally linked? And the answer here is that, well, that's relevant information for how you would actually guide your behavior in the future, i.e. come into the clinic if you have a partner of the same ancestry as you. So I think we can reject that because we can reject not including ancestral counterfactuals, and we can defend the point that it is a microaggression on the end that it's relevant for clinical explanations, and it doesn't seem to be beneficent, which is a virtue of bioethics, that we can't reject it because it's relevant for future behavior of the patients. So the last one I want to explore, this is mostly already discharged, but we might wonder why ultimate level explanations like this high level, but for your ancestry counterfactual is relevant. Why not just say that your parents had a disease gene and they passed on to you? We're going to reject that for the same reason. It's not beneficent to not invoke this ultimate level of explanation because beneficence requires it. It's medically relevant, It's different from explaining that your parents had a disease because when you're thinking about planning a family, it's going to be obviously salient what ancestry your partner comes from, especially if you have a ancestrally linked disease. So for this reason, we have to reject thinking that ultimate level explanations are not clinically relevant. They may be, maybe proximate ones are a bit more relevant but it doesn't rule out ultimate level explanations as being clinically relevant. So in conclusion here, family data and ancestrally linked data seem to be normally identical in many cases. There are some cases where it seems that they might come apart, but normatively it seems like they're quite closely linked because they're couched within each other in some ways. So explaining that ancestry is uniquely causative of disease which has environmental influence may constitute a microaggression. And that's mostly because it's just not the full causal story. And it's just not the full causal story. So we can avoid this by conceptually re-engineering how we talk about, how we clinically speak about disease states to include elements of the environment. So I believe that this diffuses the worry about microaggressions because the explanation is relevant and beneficent, and also scientifically correct and guides future patient behavior. So that's kind of my conclusion here, and that's the paper. So thanks for tuning in.